on the topic of drug used in congestive heart failure. Cardiac glycosides. Its chemistry. The glycosides consist of an A-glycone with one or more sugar moieties attached to it. They have patent action on the heart, hence are referred to as cardiac glycosides. Its source. The leaf of Digitalis purpurea, the leaf of Digitalis lanata, and the seed of Strophanthus grantus. The utility of digitalis in the treatment of heart failure was shown by William Withering. Mechanism of action of cardiac glycosides. Sodium potassium ATPase is a membrane-bound enzyme which is called digitalis receptor. It is also called sodium pump. Mechanism. Digitalis bind and inhibit sodium potassium ATPase, then increase intracellular sodium ion, which lead to decreased extrusion of calcium ion via sodium calcium exchanger, causing increased intracellular calcium ion. Here, entry of calcium ion into cardiac cell via L-type calcium ion channel during action potential also cause increased intracellular calcium ion, then increased calcium ion uptake and storage in the sarcoplasmic reticulum, lead to increased amount of calcium ion released during each action potential from SR. Then increase availability of calcium ion from excitation contraction coupling, thus increasing myocardial contractility, lead to increased cardiac output. Pharmacological action. Cardiac and extracardiac. Cardiac action. Digitalis has direct and indirect action on the heart. Direct action by inhibiting sodium potassium ATPase, indirect action by stimulating vagus. In myocardial contractility, digitalis increases the force of contraction of the myocardium. This effect is more prominent in the failing heart. Digitalized heart contract more forcibly and completely. The positive inotropic effect causes complete emptying of the ventricle during systole and increase the cardiac output. This decreases pulmonary congestion and systemic venous pressure. The diastolic size of heart is reduced when the size of the heart is reduced. Muscle fiber length is also reduced, thereby decrease the oxygen requirement of myocardium. The digitalized heart thus can more work for the same energy, therefore digitalis is called cardiotonic. In heart rate, in patients with CCF, digitalis reduce the heart rate by direct and indirect action. In small doses, digitalis decrease heart rate by stimulation of vagus. In toxic doses, it can increase sympathetic activity, thus increasing heart rate. In electrophysiological action, at therapeutic concentration, digoxin decreases automaticity and increase resting membrane potential by vagal and decrease conduction velocity in AV node. This may lead to bradycardia and AV node. At higher concentration, digoxin can increase automaticity in cardiac tissue by direct action as well as by increasing sympathetic activity. This can result in atrial and ventricular arrhythmias. In ECG, digitalis produce prolongation of PR interval, inversion of T wave and depression extracardial action. In the GIT, digitalis can produce anorexia, nausea, vomiting, and occasionally diarrhea. Nausea and vomiting is due to stimulation of chemoreceptor trigger zone and direct action on the gut. In the kidney, the patient with CCF, digitalis cause diuresis. In the central nervous system, in higher doses, it can cause central sympathetic stimulation, confusing, blurring of vision, disorientation. Pharmacokinetics. Digoxin is the commonly used glycoside and is usually administered by oral route. Food delays the absorption of digoxin. It is widely distributed in the body, concentrated in heart, liver, kidney, and skeletal muscle. It crosses the blood-brain barrier and mainly is excreted unchanged in urine. Dosage adjustment of digoxin is necessary in the patient with renal failure. Adverse effect. Digoxin has narrow margin of safety. Monitoring of serum digoxin, electrolyte level, and electrocardiogram are more important during digitalis therapy. Extracardiac. GIT. Early symptom of toxicity are anorexia, nausea, vomiting, which are due to GI irritation and CTJ stimulation. In CNS, effect including headache, confusion, restlessness, disorientation, weakness, visual disturbance, altered mood, and hallucination. Skin rashes and gynecomastia can occur occasionally. In cardiac, digitalis can cause any type of arrhythmia. The most common are ventricular premature beat, pulses by Gemini, and ventricular tachycardia. It can also cause AV block, atrial tachycardia, atrial fibrillation, atrial flutter, and even severe bradycardia. Factor affecting digitalis toxicity. Age. Elderly patients are more susceptible to digitalis toxicity due to declining renal and hepatic function. Route. Intravenous digitalization carry more risk than oral route. Hypokalemia increase the binding of digoxin to sodium potassium ATPase and enhance its toxicity. Hypokalemia and hypomagnesemia enhance digoxin toxicity. Hypothyroidism, hypoxia, renal failure, and myocarditis are predisposing factors. Treatment of digoxin toxicity. Shift the patient in ICU, stop digoxin and potassium depleting diuretics. Potassium chloride orally or intravenously is drug of choice for tachyarrhythmia when serum potassium level is normal or low. Supraventricular arrhythmia are treated with oral or intravenous propranolol. Intravenous lignocaine is the drug of choice for ventricular arrhythmia because it has relatively low incidence of toxicity, a rapid onset, and short duration of action, so it action wear off immediate effect after stopping the infusion. No action on AV node conduction velocity, hence does not intensify the AV block in digitalis toxicity. AV block and bradyarrhythmia are treated with atropine and cardiac pacing. Digoxin antibodies. It is used only in case of serious digitalis toxicity. It neutralizes circulating digoxin and digitoxin and rapidly reverses the toxicity, but it is too expensive. Drug interaction. Cholestyramine or cholestyramine with digoxin. Cholestyramine and cholestyramine bind to cardiac glycoside in the gut and reduce its absorption. Beta blocker or verapamil with digoxin. This drug has additive depressant effect on SA and AV node and may precipitate AV block. Thiazide and or loop diuretics with digoxin. Hypokalemia caused by diuretics may potentiate digoxin toxicity. Hypokalemia increase the binding of digoxin to sodium potassium ATPase. Calcium with digoxin. Calcium increase the incidence of digoxin toxicity. Digoxin with sympathomimetic or succinylcholine. The chance of cardiac arrhythmias are more with sympathomimetic or succinylcholine in patient on digoxin. Use of digitalis. In CCF, digitalis is useful in patients with low output failure, especially when associated with atrial fibrillation. It is ineffective in higher output failure associated with anemia, thyrotoxicosis, and AV shunt. The beneficial effect of digoxin in case of heart failure are due to its action on myocardium, venous system, and kidney. Atrial fibrillation. It is the most common cardiac arrhythmia. In atrial fibrillation, the atrial beat at rate of 350 to 600 per minute. Digitalis has both direct and indirect action on AV node. It depresses AV node by increasing EPR and decreasing conduction velocity, thus reduces the ventricular rate. Verapamil and propranolol can be used in atrial fibrillation. In atrial flutter, the atrial beat rapidly at a rate of about 300 beat per minute. Digitalis control ventricular rate by depressing AV conduction. In paroxysmal supraventricular tachycardia, in PSVT, the heart rate is about 140 to 220 per minute. The preferred drug for PSVT is adenosine. Propranolol or verapamil can also be used.
Digoxin has slower onset of action, hence it is not suitable for acute therapy. Digoxin is preferred in PSVT if there is associated heart failure. It terminates the arrhythmia by increasing the vagal tone. Amines. Dopamine and dobutamine are used in acute heart failure. They have positive inotropic effect and provide symptomatic relief in patients with ventricular dysfunction. Dopamine, it is a catecholamine, has a dose-dependent hemodynamic effect. At low doses, dopamine selectively dilates renal, mesenteric, and coronary blood pressure by acting on D1 receptor. Thus, dopamine increases GFR and urine output. At moderate doses, dopamine stimulates B1 receptor of heart, increase myocardial contractility and cardiac output, but tachycardia is less important. It also stimulates dopaminergic receptor, resulting in an increase in GFR. Dopamine used in cardiogenic shock and acute heart failure with renal impairment. It improves both cardiac and renal function. At higher concentration, it causes generalized vasoconstriction. This increase after load and reduce blood flow to renal, mesenteric, and other vital organs. So, beneficial effects seen with low to moderate doses of dopamine are lost at higher concentration. Dobutamine. It is synthetic catecholamine and act on B1, B2 and alpha-1 receptor. It has selective inotropic effect and increased cardiac output. In therapeutic dose, it has little effect on BP and heart rate. Total peripheral resistance is generally not affected. This is due to counterbalance of alpha-1 receptor mediated vasoconstriction and beta receptor mediated vasodilation. It is administered by IV infusion for short-term treatment of acute heart failure and cardiogenic shock. These side effects are tachycardia, rise in BP, and development of tolerance.